Bimlesh. This is the last topic before lunch, and the topic is premenopausal osteoporosis, and the speaker is Dr. Manoj Chadha. Please do come. We all are acquainted with postmenopausal osteoporosis. It is off the bit, so we should hear from the speaker. Okay, sir.
Thank you, sir. I'd like to thank Parthajit, and a very special thank to Dr. Kaushik Chaudhary for having pushed me to come here. I've enjoyed the morning session, and I realize I'm the person between lunch and you, so I'll try to get this done as fast as possible. So while I was preparing for this talk, I myself realized that there was going to be some confusion. So I'm going to talk about premenopause, as the title says, but then you realize that premenopause, perimenopause, early postmenopause, these are very difficult to separate out in a clinical setting. I mean, the purists can sit and dissect that out, but in practice, they all come between 45 and 52, 53. So that's something I'm going to define, and you might find some confusion, interchangeable use of words, but they all practically mean the same thing. A little bit about what happens in normal premenopause. Please remember that every premenopausal lady is also prone to secondary osteoporosis. So part of my talk is going to cover secondary osteoporosis. So there are three parts. The first part is just the general basic stuff. The second part will be specifically on premenopausal, and the third part would be on secondary osteoporosis. How many of you have heard about the SWAN study? Okay, so no one has heard about it, or they are too tired to raise their hand. So SWAN study, as I'll tell you in the next slide what it means, but it's one of the studies which has defined what is premenopause, perimenopause, postmenopause. And if you spend a minute to go through these slides, anything which is less than, there is a amenorrhea which is less than 3 months when you expect menopause to start, not at 25 and 30, is early perimenopause. If the gap is between 3 months and 1 year, then you're looking at late perimenopause. And then from the final menstrual period, if 1 year has passed back, then you go retrospectively and say that was the date of menopause. So then you have early postmenopause, which is between 2 and 6 years from the F is not first, it is final menstrual period. And then you have late postmenopause, which is more than 6 years after the final menstrual period. So I'll just spend a minute on telling you what is SWAN study. As it says, 1902, early to perimenopausal ladies from the Afro-American, Japanese-American, Chinese-American, and Caucasian ladies who were started to follow up prospectively in the 90s, 1993, 1994, and are being followed up to date. So there's a 30-year follow-up on these ladies. And they were looking at multiple things. Today we're going to talk about bone health, but they looked at mental health, sexual health, skin changes, cardiac things. So something akin to the Women Health Initiative study that was done years ago. So this is something. So today let's just focus on what the bone health has come up and why we need to talk of this early perimenopause and late perimenopause. Because as far as we are concerned as physicians, the maximum rate of bone loss is in the late perimenopause and the early postmenopause. That's what we need to focus on. And it could be between 2 to 5% in for 3-4 years. So we're looking at anything between 8 to 12, 14% loss of bone mass. And while we were talking of treatment in the morning, we were talking of 2-3% bone mass gain per year. So if someone is going to lose 8, 10, 12, 14%, we really do something about prevention, otherwise we'll miss the bus. You've seen this slide time and again, and I just want to stress that if you want to talk of prevention of osteoporosis at any age, whether it's post-menopause, perimenopause, or premenopause, please focus much earlier. So we are talking in terms of adolescence, because that's where the maximum bone mass increases. It continues to increase till the end of third decade, but I repeat, between 10 and 20 is the most important period. You need to see that children are playing out, eating well. I insist on specifying avoiding bone toxins, nicotine, alcohol, and the third thing, which we very conveniently ignore, and which probably all of us are guilty, is the extra salt that we eat as an Indian community. We eat too much of salt, and rarely at home, the recommendation should be 50% reduction. I'm not talking of a hypertensive diet or a kidney diet, but our normal diet, we're eating too much of salt. So that should be one of the take-home messages if you really want to prevent osteoporosis. We've heard in the morning workshop that when we talk in terms of osteoporosis post-menopausal, we refer to T-scores. But in the pre-menopausal women, and although not a part of the talk, but men below 50, we refer to Z-scores. And in the normal set of people, we don't use the word osteoporosis. We say below expected range for age, that's below, the bone mass is less for age, or we say the bone mass is normal for age, so that if the Z-scores are above -2, we say that they are reasonably acceptable. You would use the word osteoporosis, osteopenia, obviously in someone young who's fractured. Then it becomes something to worry about. But in day-to-day terminology, it's less bone mass for age. That's what we should keep in mind. Another term probably, which maybe you're not aware of, I also picked it up thanks to my colleague Dr. Sanjay Badada, that from the time we are talking of late perimenopause, that's about 1 or 2 years of late perimenopause, going into 2 years of postmenopause, so that's between 3 and 4 years, that transition phase, they use the word transmenopause. And that's very important because, as I told you from SWAN study, the maximum bone loss is between late perimenopause and early postmenopause. So that's what you're looking at, transmenopause. And very quickly, if you can see, at this time, the FSH is going up, the estradiol is going down. The urinary NTX, or if you were to do a serum CTX, that's where it's going up, and the BMD is going down. So the FSH going up, the resorption marker going up, and the BMD going down, that's maximum that's happening in transmenopause. We'll come back to this, why this is important. I mean, you can guess it, but I'll still show you that in one of my slides. The next part, when we are talking in terms of premenopause, we cannot afford to forget that majority of ladies undergo pregnancy and lactation during this time. And nature is wonderful. There is loss of bone which could vary between 2 and 8% because of pregnancy and between 6 and 10% because of lactation. But, you know, the Sarkar keeps talking of delay the second pregnancy for 2 to 3 years. But that's a very good scientific reason, because in the next 12 months or so, the lady actually gets back whatever bone mass she had lost. And there is one study which says that 1, 2, 3 pregnancies, the bone mass turns over, and by the time she's had her third pregnancy, she has a new bone skeleton. So it's not all that bad, yeah, but provided nutrition is taken care of. Because along with the bone toxins, you must remember about nutrition. There have been 2 good talks since morning. Another rare, but you should be aware of is because we were talking about low bone mass in males also. There is a condition of juvenile idiopathic osteoporosis when you don't have a cause. And in this so 30, 40 years, still away from the perimenopausal age, you can have idiopathic osteoporosis in this age also. And we're not, as the name indicates, we're not sure what is really happening, but they may present with fragility fractures, and that's why you should be aware of this. Let's look at one 45-year-old lady. Her have just started getting irregular. So for the sake of definition, she's in the early perimenopause. Her biochemistry, as you can go through the whole thing, looks pretty decent. Vitamin D is 30, PTH is 34, CTX is low, middle, normal, P1NP is 42, which is again decent in terms of bone formation marker. I'm not sure if you can make out the DEXA scan, but I'll read it out to you. The T-score at the lumbar spine is minus 1.7, and at the hip is also about minus 1. So it's not bad. And she's just, getting into perimenopause. So now the focus is why this is important. I've already told you that the bone density decreases pretty rapidly in these 4-5 years. So this is giving you an opportunity to act. So physicians, gynacs, family physicians, these are the people who should be aware that they can do something about it. And what is that something? Whether we're looking at exercise, weight-bearing exercise, whether we're looking at the diet, again I repeat, avoiding bone toxins, and avoiding falls, because most fractures happen when they fall down. So this is like saying that this is a low-hanging fruit. Now, someone may get up and argue that, oh, this is not osteoporosis. Why are you worried about fractures? This is a very famous study from Scandinavia, which tells you that most osteoporotic fractures don't happen at minus 2.5 and minus 3, as has been defined. They happen around minus 1.5, because that's where the largest population is. The large numbers, so even if it's a small percentage of fractures, but the fractures are more. It's like saying, between type 1 and type 2 diabetes, which one is likely to have more chronic kidney disease? So as a percentage, type 1 moves faster into chronic kidney disease. But as a number, when we are saying 95, 98% of the diabetic population is type 2, so the type 2 population is likely to have more chronic kidney disease. So that's why this low-hanging fruit is something that we can work on. I have deleted some slides in terms of the pathophysiology and physiological changes, but just to tell you that the initial bone loss when we enter into perimenopause is trabecular bone loss, because estradiol deficiency, the osteoclasts start working faster or more. And as the person ages, it goes towards what's called as senile osteoporosis, but it's basically a defective osteoblastic function and a defective 1-hydroxylation, which sort of works together and ends up in further bone loss. So this index case that I was talking of, within 6 months, if you notice, we did ask another DEXA scan, but I'll show you that later. But you can see here, the FSH has started rising, the estradiol has started going down. It's less than 25 now. 25 hydroxy-D, PTH are all normal, but now the resorption markers have gone into the postmenopausal range, and the P1NP has followed it, which in a way is protective, but the fact is that now there are evidence to show that she's losing more bone mass. And the DEXA from minus 1.8 or so has now become minus 2.9. So whatever has changed in these last 6-8 months, she has now entered into a phase where you really need to think in terms of specific therapy. Earlier it was just the non-pharmacological therapy, good lifestyle advice, but now you have to think about something specific for her. Various hormones changes have been described in the pathogenesis of these phases that I've been talking about. So traditionally we talked about low estradiol, escape of osteoclast function, more bone resorption. But when we are looking at what is happening during perimenopause, The estradiol levels are still within the normal range. It's the FSH which has started rising up. So probably, and now there is literature to support that it's not the low estradiol primarily, but it's the rising FSH which is causing the problems. And as a corollary, you know that in subclinical hyperthyroidism, say in thyrotoxicosis, you're worried about bone mass loss. But in subclinical hyperthyroidism, the definition is a low TSH with normal T3, T4. So it's not the normal T3, T4, but it's a low TSH which is a culprit. And similarly here, it's not the estradiol primarily, but the the high FSH which is causing problems. In addition, things like inhibin B, activin, they also come into play. But please remember that age is an independent factor which leads to bone loss. Yeah, so wherever you have the facility, it's worth looking occasionally at the bone mark. It's not absolutely necessary. And if you do not have a lab with standardized reports, it's better not to ask the patient to spend money on bone markers. You have formation markers, P1NP and bone-specific alkaline phosphatase, and you have resorption markers, CTX or NTX. You don't need to do everything. You can do one of each and you get some answers. So in the perimenopausal women, you see that the resorption markers go up much more than what you would expect in normal situations. So the lady who transitioned very rapidly from the early perimenopause to the late perimenopause or early postmenopause, we have lifestyle changes to talk about, bone toxins, prevention of falls, which is very important. Exercise, walking is not enough. Swimming doesn't help here because the body is weightless. So you need to have weight-bearing exercise and strengthening exercise. Worth looking at a fracture risk assessment score. What we are generally have easily is a FRAX score. Bone density may confuse you a little, so don't rely only on BMD, but look at the FRAX score. And if you feel that the fracture risk is high, especially if this is a patient who's got some other underlying secondary disease or has received steroids or has a family history of hip fractures, you might think of using an anti-resorptive treatment in the early stages. And if there's already a fracture, especially at the spine, then it becomes anabolic agent as the first choice. We've had discussions on that, so I'm not going to go into the details. The important thing is that we really don't have clear-cut guidelines on screening for perimenopausal women. None of the guidelines, whether it's from NOF, whether it's from NICE, whether it's from India, we are not clear. So the history taking is very important. High risk of fracture. I mean, if the lady has already fractured, then there's nothing to sit and discuss. But we're talking of high-risk patients. Someone has been losing too much of weight, someone not eating well, some menstrual irregularities for a long time. It's worth looking at a BMD. Otherwise, unfortunately, a lot of corporate hospitals include BMDs for even 25 and 35-year-old ladies, but that's a separate chapter. We now shift to the second part. Like I said, nothing stops a premenopausal lady from having secondary osteoporosis. So if you have someone who has already fractured, someone, I can remember one of my patients had poorly controlled diabetes and hypertension for a couple of years, and she turned out to have Cushing's disease. So something which is not a garden variety story, you must think in terms of secondary osteoporosis. And if you looked at the Z-score for some reason, and if it's less than -2, then think of secondary osteoporosis. If you look at the extreme left, in men, at least 58 to 80% of them have secondary osteoporosis. In premenopausal women, it's more than 50%, and in postmenopausal women, it's at least 30%. This diagram gives you the common reasons that you should be thinking of, especially endocrinological, renal, drug-induced. That's a big factor in our societies. Nutritional, GI, hematological, oncological, malignancy, etc. But I made it simpler for you from this table. It gives you the common causes of secondary osteoporosis instead of just giving you a full list, which you'll anyway get it in any standard textbook. But iatrogenic thyrotoxicosis, an important clinical cause. Hypercalciuria, celiac disease. Traditionally, we've been taught that you don't get celiac disease in the South. It's only a problem of the wheat-eating North Indians, but not really. You must do a test. If you are suspecting secondary osteoporosis and the regular tests are all negative, think of celiac disease, get an anti-TTG done, or try to adjust the diet and see what happens. Hyperparathyroidism, not a very common disorder, but easy to diagnose, and you look like a fool if you miss that out, and start thinking of medical treatment before looking for other secondary causes. And although when we say vitamin D deficiency, it's not osteoporosis, it's more of an osteomalacia. But one of the commonest causes of low BMD in the young age group is vitamin D deficiency. So that's why I've kept it here. The common set of investigations that you like to go through, I'm not going to read it out for you, but the standard CBC, urine routine, calcium, renal function test, liver function test, these should be done. I'm not a great fan for writing 25-hydroxy-D in every patient. PTH, definitely if I find the calcium is high or high normal. This is just to complete the list, don't bother. It tells you that there are a whole lot of specific investigations when you're thinking of a specific secondary cause, whether it's liver, kidney, and things like that. So the important thing is when you're looking at managing premenopausal, perimenopausal, or secondary osteoporosis, all put together, you must look at the history properly, try to get what has happened, investigate the underlying cause, and obviously if there is an underlying cause, it needs to be treated first. Very often, like I said, 50% of the times you'll get a secondary cause, but in 50% there is no primary secondary cause. And then the primary cause will depend upon how you change the lifestyle factors, specific treatment for osteoporosis based on your judgment. One thing you must remember, especially for the younger generation, is there is no hurry to start treatment for osteoporosis, the medical treatment. Nothing happens if you take 6 months to 12 months to make a decision. Why I'm saying that is because we've been taught that you should do a BMD after 2 years or 3 years of treatment. But sometimes when you hold your treatment and repeat a BMD after 1 year, you can get clear-cut answers. By changing the lifestyle, the BMD has actually improved. Please don't look at the T-scores, look at the BMD. And if you've missed out something, the patient may worsen, but really nothing happens when you're looking at, say, from 50 to 90, 40 years of treatment. If you delayed it by 1 year, nothing is going to happen. And you should know what to do what to expect when you start treatment, because it's not like treating blood glucose or blood pressure that within days you start seeing the changes. I'm going to end my talk with something very interesting. I don't know if you can make out the X-ray or the MRI, detailed compression. There are another 1 or 2 lumbar vertebral compressions. So why am I showing you this X-ray? So this is a young lady, 31, primary, just delivered 3 months earlier. She was breastfeeding a baby and came with significant backache. And the orthopedic surgeon, the spine surgeon, rightly picked it up on the MRI and then referred her to me saying that this is not in my syllabus, this is beyond my syllabus. So we have this condition called pregnancy and lactation-induced osteoporosis. How many of you have heard about this or seen such a patient? 1, 2, okay, 3, 4, yeah. So the largest series globally is about 110 cases or so. So just to tell you that it's not common, but it's not rare to that extent that we don't, only 4 people raise their hands. I talked about pregnancy, I talked about regular bone loss in pregnancy and lactation and how they recover if they wait for 6 to 12 months. But this seems to be something beyond the regular pregnancy. There may be, there are unclear factors, I'm not going to go into that today, but just to tell you that please, when you see a postpartum lady, besides how are you and are you feeding your baby and things like that, please ask them about aches and pains, which may be not simple pregnancy induced, but fracture induced. And it becomes important. One is the lady is miserable. Secondly, there's a controversy to allow breastfeeding or not. And thirdly, there's a big issue if they're going to go for a second pregnancy. So this is an important chapter to keep in mind. Most of my talk material has been taken from these three references, which I'm showing for those who are interested, especially the students. Endocrine Clinics of North America, March 17, Clinical Obstetric Gynec. So these are available for free on the net, so you don't have to worry. And the secondary osteoporosis is a wonderful review article by Peter Eibling in Endocrine Reviews. So, ladies and gentlemen, I think I've tried to make a case that in normal females, ladies, with time, with aging, there is a transition in bone health. We are looking at a wonderful peak bone mass, but it really doesn't happen in a large majority of our people. FSH and bone resorption markers may give you an idea. Another expensive test that you can do, at least in some of our corporate hospitals, is AMH, but I'm not recommending that out here. If you find that the bone density has gone down for some reason and there is no obvious secondary cause, then lifestyle changes, calcium, vitamin D, diet, exercise, and avoiding bone toxins should be the mainstay of treatment, not rush into treatment for osteoporosis. Because unlike hypertension, diabetes, thyroid, where you can give treatment for lifelong, your treatment for osteoporosis is for a finite period. We still don't have published guidelines from any society on what to do with perimenopausal bone loss and BMD screening. But fall prevention is the cornerstone, because muscle strength and fall prevention would prevent osteoporotic fractures to a large extent. I love to show this because this is a bird, an animal who feels that everything is around me is normal. This doesn't really concern me. But I used to say that all doctors have to think about osteoporosis, and now it started becoming personal because I think I can see most of us are 50 plus. So please look at it personally. And you may have the best interest of the patients in your mind while you're prescribing, but please ensure that the patient is taking your prescription. Thank you very much.